kind of thing where you make a keyhole box to dispose of needles and sharps safely. It is wide at one end and narrow at the other end, as you can see. So this is for syringes. So the bottom one is for syringes and the top one is for needles. You know, you can make it with anything you want to, but the fact is that you can always dispose them off into these sharp containers. And of course, this is just telling you as to how you should be putting the syringe in and putting the needle into these specially designed containers, keyhole containers. Now what happens in case an accident does happen, you know? A needle stick, despite all your precautions or the lack of it, a needle stick injury has taken place. That is very important, because at the end of the day, you should try to prevent it as far as possible, but it is not 100% preventable. You will have it. We can minimize it, but we cannot prevent it completely. So first thing is, do not panic. Not all needle stick injuries are dangerous, so it's only a small percentage which actually cause problems. So you need not panic. Encourage bleeding from the wound by squeezing gently. So don't just stop it immediately, as would be the general tendency. The moment you have a prick, stop it. No. Squeeze it. Let that 1 or 2 drops of blood come out. It is not going to do harm to you. It may do a lot of good to you. So the first thing is, instead of pressing and stopping the bleeding, squeeze it and allow 1 or 2 drops to flow out of it. That is number 1. And then clean it with running water. Running water and soap. So soap and running water, wash it and keep washing it for about 10 minutes. No issues. So whenever there is a needle stick injury, don't try to stop the bleeding, try and encourage to get it out, and then clean it with soap and water for about 10 to 15 minutes. No issues at all. And then of course you can put after that you can put an appropriate antiseptic and dressing. Now very often we ourselves, if we get a needle stick injury, all we will do is we will take the glove out, put some betadine there, and that's it. But actually you should wash it with soap and water for 10 minutes, then apply whatever you have to apply and put a small band-aid or whatever you have to do. So that is how you should actually deal with it as far as the first aid is concerned. And of course, whenever there is a needle stick injury, it has to be reported to a designated person. I really do not know whether we have a designated person in the hospital or not, but at least report it to some doctor so that, you know, subsequently you can get the correct management protocol. Well, where water is not available, a non-water cleanser or antiseptic can be used to wash the skin. Now generally this is a very rare situation where water will not be available. But in case it is not, you can use spirit and the other sterilium or things like that. If you have them, you can use them. But generally speaking, water is available most of the time and you should be able to clean it with soap and water. That's very, very important. Now, fair enough, you've done the first aid part, you've washed it with soap and water, you've applied your dressing. Next, what do? You obviously go to the next man, and then what do you have to do? So basically, we are looking at 3 main problems. One is HIV, one is hepatitis B and hepatitis C. So, now this is important. Where the source patient comes from a high-risk group and the HIV status is unknown, post-exposure prophylaxis to HIV should be offered. You know, all our patients do not have HIV testing done. And all of you may be aware of the fact that it is not legally permissible to do HIV testing casually for anyone. It's a complex procedure, though we may not follow it all the time, but it's a complex procedure. Whatever be the case, the fact of the matter is that all patients in the wards do not have an HIV test performed on them. But if you have a needle stick injury either in the OT or in the ward as a result of IV infusions or whatever, in a patient who has greater propensity, who may be belonging to a high-risk group, he's an alcoholic, he's, a person of dubious character, maybe coming from a different section of society, wherever you feel that there is a possibility of a high-risk chance of an HIV, you do not wait for the HIV result to come before you actually start or do not start post-exposure prophylaxis. So the moment, if the patient is of unknown unknown HIV status and he comes from a high-risk background, then you should start the post-exposure prophylaxis of HIV within 1 hour of the injury. So that's important. You have to start it within 1 hour. Tests, etc. will happen later. So it is inappropriate to await the result of an HIV antibody test in a high-risk patient before commencing prophylaxis. That's very important. The exposed person should be given hepatitis prophylaxis since the risk of developing hepatitis, as I told you, after contamination with blood is much more than HIV. A baseline HIV test should be carried out immediately since seroconversion will not have occurred immediately after surgery. So this is also important, that a baseline HIV test should be carried out. So you have been pricked with a needle, unknown person, you should get your HIV blood test done. You may be HIV infected anyway, who knows? We may have been infected earlier. We also don't get our HIV tests done regularly. So your baseline test is the first thing that you should do. You have come with a needle prick injury, high-risk patient, well, you should start on post-exposure prophylaxis within 1 hour, but you should also send your blood for HIV testing. And then, not only that, because it may not come, see, even if it is infected, it may not come positive, because it doesn't get positive immediately. That is just a baseline test, because you may be already infected, in which case the treatment will be completely different. Then it is not post-exposure prophylaxis, then it is treatment. So then it is completely different. But even if you are negative, you should still get yourself repeated. You should repeat the HIV tests at 6 weeks, 12 weeks, 6 months and 12 months. I hope you get my point. You have been punctured. You must get your HIV status determined immediately, because you need to know what your baseline status is. We have been working in the ward, we have been working in the hospital, we may be infected anyway, who knows? So we must get our baseline status. If it is positive, then we have to be treated differently, then we are HIV positive ourselves. Then I think the patient needs to be more careful, whatever. So the moment it is, baseline test has to be done, but that is not enough. You will have to get your test repeated at 6 weeks, 12 weeks, 6 months and 12 months. Generally, if it has to come positive, it will come positive by 12 months. So this is the protocol that is recommended. It may come positive later also, but that is very, very rare. So the recommendation is that these 4 tests after a baseline test should be done even if you are negative, at the baseline. If you are positive, then it's a different issue altogether. And of course, you have these different regimes which are used for HIV post-exposure prophylaxis, like you have azidovodine and lamivudine. Even I am not experts on these medicines. I think Dr. Jha and others would know much more. And alternative regimens like tenofovir and lamivudine, stavudine and lamivudine. See, these are post-exposure prophylaxis regimes which the concerned doctor who deals with this is supposed to know. But the point is that what all do you need to do? You need to wash your hands, soap and water, very important. You need to you need to get the blood out, wash your hands, put the bandage on, get a post-exposure prophylaxis, get your HIV test done, then go for these regimes. These regimes will be known to most of the doctors. So this is the post-exposure prophylaxis regimes, and these are the doses. Zidovudine 250 milligrams twice daily, lamivudine 150 milligrams twice daily, and indinavir 800 milligrams thrice daily for 28 days. This is the post-exposure prophylaxis regime. And these are some of the other regimes which, there are a number of regimes which can be followed. The United States, of course, has produced guidelines, and they keep updating these guidelines. And of course, they say that prevention is definitely much better than cure, and secondary prevention and comprehensive education, etc. must be given to all of them, including the principles of post-exposure management, like these kind of CMEs. What about hepatitis B and hepatitis C? Because these are the other 2 dangerous things. What do we need to do about these? So, in case there is a needle prick from a known case of hepatitis B, now hepatitis B patients are very common. So, if there is a known patient of hepatitis B, what do you do? Now, most of us are actually vaccinated. So, if we have been vaccinated with a full course of hepatitis B, do we just sit back and relax? No. We should get our hepatitis B titer, antibody titer checked. I know a few of us had gone to the United Kingdom, and there they routinely check for your, all the 4 doctors were vaccinated against hepatitis B. They got the antibody titers checked, and 3 out of the 4 had antibody titers which were very, very low. So, you know, because there are a lot of issues there, because there's this cold chain maintenance, this, that and the other. So you may think that you are completely fine, but even if you are vaccinated against hepatitis B and you get a needle prick from a hepatitis B patient, you are supposed to get your antibody titer checked. If it is normal, you don't require to do anything, fair enough. But if it is less than normal, then you require to give 1 booster dose. Okay? So this is the take-home message. Hepatitis B positive, you prick yourself, get your antibody titer checked. It's not enough to have been vaccinated, because you may not be having proper titers. So you have to get your titer checked, and then 1 booster. If it is normal, you don't need to take anything. And of course, the normal dose schedule of hepatitis B vaccine, in case you have not taken it earlier, if you are not vaccinated, then of course it is 0 months, 1 month, 6 months. That is the standard schedule if you are not vaccinated. But ideally, all of us, all of you are vaccinated. I'm not. Everybody. Nobody who is not vaccinated here. Good. Huh? Cannot? One sister.
Most of them are vaccinated.
Oh, vaccinated. Okay, fine. I thought not vaccinated. Okay, but even if you are vaccinated, you don't assume that you are clear. You have to still get it tested.
5 years.
And hepatitis C. But hepatitis C is a different ballgame, because you do not have vaccination against hepatitis C. So, hepatitis C, HCV antibody and liver function test should be done. That is number 1. At exposure, because there is no vaccine to it, so you can't give anything prophylactically like that. But at exposure, you will have to get your HCV antibody, baseline antibody, liver function test. 3 weeks, 6 weeks, 12 weeks. So once again, you have to get your hepatitis C tested 4 times. At exposure, at 3 weeks, it's not enough to get it done once. At 3 weeks, 6 weeks, 12 weeks. And at any stage, if the test comes positive, then you are to start treatment with regulated or unregulated interferon with or without ribavirin. That of course can be taken care of by the liver expert, but the fact is that this is what you need to know, that hepatitis C does not have a vaccine against it, number 1. So none of us are vaccinated. None of us can get vaccinated as of today. If we get exposed, the only thing that we can do is we will have to see our HCV antibody and liver function status. Not once, but 4 times. At exposure, 3 weeks, 6 weeks, 12 weeks. And if it comes positive, then you need treatment. You need treatment for your condition. And of course, you need follow-up with HCV viral load testing if liver function tests are abnormal. And the recommendations, of course, as I mentioned, all healthcare workers should be vaccinated against hepatitis B. This, of course, is the American recommendation of combined hepatitis A and B vaccine. Normally in India, we don't use much of A vaccine because all adults are naturally immunized to hepatitis A, because that generally happens in childhood and all of us are almost vaccinated naturally, but in the West they are not. So in the West they have to take hepatitis A as well, but for us A is not that important as far as vaccine is concerned. And post-exposure prophylaxis with hepatitis B vaccine, hepatitis B immunoglobulin or both should be started, this is another important, within 24 hours and no less than 1 week after exposure. So preferably you should start within 24 hours. Don't go on dilly-dallying waiting. So you have to, so hepatitis B normally now you are vaccinated, fair enough. So you have to get your antibody titer done immediately and then you start the treatment within 24 hours and certainly within 1 week. Not after 1 week, then the effect is not much. So that is also very important. So don't dilly-dally. Now, and of course, hepatitis B positive healthcare workers should receive clinical evaluation and their serostatus as well as risk for hepatitis D should be assessed. Serological follow-up is not recommended when post-exposure management is managed according to these recommendations. So if you have taken hepatitis B vaccine, you have done the antibody titer, your dose is low, you have taken a booster. You have done the antibody titer, you have normal antibodies, you don't take a booster, fair enough. After that, you don't need to follow. It is not like hepatitis C or hepatitis or HIV where you have to do 4 or 5 tests in order to determine that. In hepatitis B, once you have followed the protocol, then you don't need to go on testing it repeatedly. And of course, the fact of the matter is, we have this tendency, it is wrong, but sometimes in our setups we do it. When we always keep a mark on hepatitis B, this is HIV, this is that. Actually, I do not know whether you are aware or not, but all this is grossly illegal and punishable by law. If you are going to have, labels hung outside on patients' beds saying this is HIV positive, this is seropositive, this is biohazard, this is those kind of labels, if they are hung out on patients' beds, they are actually illegal and can be punished by law. Now, in our country, we generally get away with it, so it is fine, but it is, and why is it so? Because we are supposed to follow universal aseptic precautions. And what is the meaning of universal aseptic precautions? The basic meaning of universal aseptic precautions is that every patient that we deal with is to be